Hello, hi, and we'll be solving another clinical scenario by ADC today. I'm just going to quickly go through the scenario. It's an easy one. Again, a patient like this can be your daily encounter, can be your weekly encounter. This is basically for caries and how to manage it and regarding reversible pulpitis. Like a very common scenario. So, you as a clinician should be knowing about this. This is from the ADC practice paper, which I'm sure by now you all must have it on from the ADC website. And let's just right away solve through it as I have to go and pick up my son in the next 10 minutes. So, David is a 25-year-old laborer who works long hours outside in the tropical north of Australia on a large building site. Okay. He attends your surgery as an emergency patient, complaining of pain in the upper right region. David also tells you that he occasionally wakes up with a sour taste in his mouth. What does this mean? Why is this line important? Sour taste in the mouth, he has an acid reflux, that is what it means. So he's got a bit of a reflux, and that is why when he wakes up, he has a sour taste in the mouth. David has poor oral hygiene, and during the course of the day, he drinks cola continuously, high sugar, very high sugar, and smokes about 5 cigarettes. David has not visited the dentist for many years and advises that both of his parents wear complete dentures. So basically, the teeth condition of the parents also is not well. Probably that's why they have been extracted or they got lost due to periodontal problems, and they both are having complete dentures. On taking a history of pain, your provisional diagnosis is reversible pulpitis in tooth 1, 2. So already you have done some form of questionnaire asking, and you have done some sort of clinical examination, and that's how you have determined that it's tooth number 1, 2 which is giving him a problem, and probably that is reversible pulpitis. So basically I can place this question in diagnosis and management, right? Information gathering has already been done. So this is a question from diagnosis and management cluster. You can get the same question in your ADC Part 2 exam in your communication OSCEs. Now, what is the most likely description of David's pain symptom that would lead to your provisional diagnosis of reversible pulpitis in tooth 1, 2? So basically, what made you think that it's reversible pulpitis and not irreversible pulpitis? Spontaneous throbbing pain lasting several minutes. Whenever there is spontaneous pain, it has to be irreversible pulpitis because there is no trigger. Reversible pulpitis always will have a trigger, and that trigger will be either cold or an extreme hot thing, but mostly it has to be a cold stuff, and the pain has to be mild and it has to go away within few seconds, and the pain should only be present in presence of a trigger. Anything apart from this is a separate diagnosis of the pulp. Sharp pain on biting, again it's sharp pain, and if it is a sharp pain, it cannot be reversible pulpitis. It's either a cracked tooth or it is an irreversible pulpitis. Severe pain lasting several minutes after a hot drink, definitely a case of necrosis, not reversible pulpitis. Mild pain lasting several seconds after a cold drink, yes, that is a classical symptom of reversible pulpitis. Pain on pressing his upper lip over the root of tooth 1, 2, no. If there is a pressure pain, that means some periapical issue is happening, so that cannot be a reversible pulpitis. So straight away the answer is D. Very straightforward question, straightforward answer. Now, what investigation would be most useful in confirming your provisional diagnosis of reversible pulpitis in tooth 1, 2? Now, you already know that it's a reversible pulpitis, but you just want to confirm it. So you will try to elicit the same symptom that he's having when he has a cold drink. Basically, he has mild pain when he has a cold drink. So the first test that you always do would be dry ice, that is carbon dioxide. You know that spray, it's you just cool it over a cotton and you place it over the tooth, and you ask the patient how do you feel about it. Basically, you want to elicit the same symptom that he has when he drinks cola. So option B is the correct answer. Option A, reversible pulpitis, you will see nothing on the radiograph, so it's useless. Electric pulp tester, no. Heated gutta stick? No. Apply hot water? No. These things you would do to determine necrosis or irreversible pulpitis. To diagnose a reversible pulpitis, you will always take carbon dioxide. And if the patient says, I have sharp shooting severe pain, then you would move on to electrical pulp test or a heated gutta or a hot water. But the first and the foremost is always dry eyes. In discussion with David, you agree to proceed with restoring his tooth 1-2 at today's appointment. You administer local anesthesia, establish a cavity outline, and remove caries at the dentino-enamel junction. It then becomes apparent that if you remove all the soft pulpal caries on the floor, basically of the cavity, the pulp will be exposed. So, what is the best way to proceed prior to placing the final restoration? See, now in this option, I do not agree with the answer given by the ADC. The ADC has given option A. They say that you remove the caries, you create a rim of sound dentine around the pulpal caries and seal the caries with an adhesive resin-based composite restoration. Basically do a compomer, that's a glass ionomer with a composite restoration. When there is soft caries, I feel you should either place zinc oxide eugenol or a calcium hydroxide and re-enter the cavity. See, if you are doing zinc oxide, then you have to let the pulpal area heal, tertiary dentine to form. Then you re-enter after 3 months or so, excavate the caries and then put a restoration. Or you do IPC. IPC is indirect pulp capping. In that you place calcium hydroxide over the caries, fast settable calcium hydroxide, and then you put a resin restoration. You will not put a resin restoration directly over the pulpal caries. But that is what they have said, that they want the answer A. I do not agree with it. I would still choose answer E, but you may choose answer A or E. This can be one of those unmarked questions. So this is one of those questions where I am not agreeing with the ADC answer. This is not how you practice clinically. Option B, C and D, they are directly entering the pulp. You don't have to enter the pulp because it's not irreversible pulpitis, it's reversible pulpitis. So you need to sedate the pulp, you need to help it heal. So though I would choose personally option E, but these people have given the option A, so you can choose the answer for yourself. David returns to your surgery for a comprehensive examination as he now has concerns about his overall health. You carry out a caries risk assessment to assist the development of your management plan. Aside from poor oral hygiene, what is David's main caries risk factor? Sugar, high sugar. He's having cola drinks continuously. Straight away option E, high sugar intake. Don't think of anything else. Smoking will come later, reflex will come later. The first and the foremost main caries risk factor is sugar, and that's high sugar intake because he's having cola drinks continuously. You also diagnose caries on the mesial surface of tooth 4-6, and after discussing your findings with David, decide to place a mesio-occlusal resin composite restoration. MO basically. What process is most likely to ensure optimal contact between tooth 4-5 and 4-6? The answer is a sectional matrix system with incremental placement of composite, because the rest of the other options give you bulk filling composite and you never fill the composite with bulk. You always do an increment placement of composite. So that should be your answer. So I hope this is clear, and have a happy studying, and we'll solve more questions and discuss more later on. Thank you. Bye-bye.